Welcome to the monthly podcast presented by JAMA Health Forum. I'm Dr. John Ayanian, the director of the Institute for Healthcare Policy and Innovation at the University of Michigan and the editor of JAMA Health Forum.
And I'm Dr. Melinda Buntin, Bloomberg Distinguished Professor of Health Policy and Economics at Johns Hopkins University and the Deputy Editor of JAMA Health Forum.
JAMA Health Forum is a peer-reviewed, open-access online journal focused on health policy, healthcare systems, and population health, and one of 12 specialty journals in the JAMA network. Our podcast each month presents highlights of new content from the journal, including timely interviews with authors of research studies and commentaries. Follow us on jamahealthforum.com, on Apple Podcasts, or wherever you get your multimedia, and on jamanetworkaudio.com.
Our guest author today is Dr. Lawrence Casalino. He's the Professor Emeritus of Population Health Sciences and former Chief of the Division of Health Policy and Economics at Weill Cornell Medicine. His research focuses on the intended and unintended effects of public and private policies on providers and provider organization. He is the senior author of a new study in JAMA Health Forum titled Physician Altruism and Spending, Hospital Admissions, and Emergency Department Visits. Welcome, Larry.
Thank you. Glad to be here.
We're glad you're here too. And I was hoping to start by asking you to tell us the story of the genesis of this very interesting study.
I've been interested in physician professionalism for a long time. Is it real? Is it a real thing? And if it is real, does it matter? Many physicians and physician professional associations claim that professionalism is an important safeguard for patients, practically a metaphysical essence. And one of the core tenets of professionalism, if it does exist, is putting the patient's interest above your own interest. That is altruism. But do physicians, in fact, do that? And to what extent do they do it? Perhaps surprisingly, there's almost no evidence about this empirically. So when quite a few years ago now, I met Jing Li and found out about the work she was doing and that there's an opportunity to measure physician altruism using a validated economic experiment, I was quite excited. It turned out to be an opportunity to work with Jing, who's a co-first author on this article. So I was quite eager to get started. The first paper published last year, we found that practicing physicians in the country are on average more altruistic than a sample of the general population, quite a bit more, and a lot more altruistic than an elite sample of wealthy people. In the research that we're going to be discussing today, we asked the question, do patients of altruistic physicians get better outcomes?
Thanks, Larry. Can you briefly tell us about your physician altruism experiment and the data that you linked to those data on altruism? Participating
physicians sit at their computer. There's a computer program that generates a series of 25 graphs, each with a line with a different slope. It doesn't take long, but each time the physician chooses a point on each line, and that determines the amount of real money that the physician will receive and the amount, if any, the physician chooses to give to the other person. The other person is not a real patient, but it is a real person. It's an anonymous other person drawn randomly from the Understanding America study panel at USC. And it's a broadly representative panel of the U.S. population. And up to $250 could be allocated between the two, or the physician could take it all. Then put simply, we measured the degree of altruism by measuring the amount that the physician allocated to the other person compared to what they allocated to themselves. It's really important to note that physicians, we couldn't do this really if physicians knew the experiment was about altruism. There'd be too much social desirability bias, right? Physician understanding was that this experiment was an experiment in physician decision-making. We'll send results out after the article's published, and they'll learn the truth. So as a physician, I was initially skeptical about this method, as I think a lot of physicians would be about economic experiments. But work using it has been published in Science and top economics journals, and my initial reaction was it's good enough for Science in those journals. It's probably a good enough method for me. The method has been shown in other studies to predict real actions in the real world. For example, in Jing's first paper, actually, medical students who were more altruistic, characterized by the experiment as more altruistic, were more likely to report choosing low-paying specialties like primary care, and less altruistic, more likely to choose like plastic surgery. And this has been found in other populations too, similar findings like with law students. So 250 physicians in 43 practices participated in the experiment. And once we did the experiment, we then used Medicare claims data to measure the outcomes for 7,600 patients who we attributed to these physicians. These were cardiologists and primary care physicians. So for outcome, we used three outcomes. We used total Medicare spending over a year. But more interestingly for the study, I think we used so-called ambulatory care-sensitive admissions, which are admissions that are thought to be potentially preventable in large part due to good outpatient care. and also potentially preventable emergency department visits, many of which probably can also be prevented with good and accessible outpatient care. So those were the outcomes we used. And then we just conducted statistical analyses. Probably shouldn't say just, but we conducted statistical analyses to determine whether patients of more altruistic physicians had better outcomes as we measured them.
So, wow, that was an excellent summary of a very complex set of data merges, experimental evidence, and claims. Tell us what you found.
Patients of altruistic physicians were much more likely to have any potentially preventable admission to the hospital or potentially preventable ED visit. 38% fewer patients had an ambulatory care sensitive admission, and 41% fewer had a potentially unnecessary ED visit. And annual spending, this is harder to interpret, was about $800 lower in a year. We did the same analysis on patients with relatively low incomes, patients of racial/ethnic minority groups, and for sicker patients, and we found very similar results. We actually thought that the results might even be more striking for patients who potentially could use more time and effort from the physician. I don't think we had a big enough sample size to really find that, but we found very similar results. We also had the physicians complete a very brief survey after they completed the experiment. And we found that on average, the physicians who we classified as altruistic turned out they reported spending more time per patient visit during office hours and more time at home on communicating with patients. And again, the physicians didn't know when they were completing this survey that the research was about altruism.
So, Larry, as a follow-up to some of those interesting survey data you just described, what are the thoughts of you and your colleagues on this study and what might explain this association? You suggested a couple ideas. Are there other ways that you think this measure of altruism may be related to the care that physicians deliver?
I think anyone who practices medicine, and I'm referring to physicians in our talk, and that's who the study was about, but you could say this about nurses or nurse practitioners or physician assistants or anyone who really takes part in caring for patients. It becomes obvious pretty early, I think, that the amount of effort and sometimes time that you put into caring for patients really matters. And if you really care about what happens, you have to be willing to put more time into patients who need it, who are often patients but not always, in the groups I mentioned. Typically, the way physicians get paid, you really don't get compensated for that time. Mostly you just get home later and miss your kid's soccer game or dinner or whatever. So it really is a form of altruism, I think, to make that effort. So I think that's the most obvious mechanism to us, and it's somewhat supported by our survey results. There may be other mechanisms too, and I hope that there will be other people who build on this research and look into that.
What do you see as the implications of your study for policymakers and for clinicians, for example, leaders of medical groups recruiting physicians to join their group?
Yeah, or people are choosing who gets admitted to medical school. A big picture, why do I think professionalism can be or should be vitally important? The most obvious reason is that most of what physicians do isn't measured, and it probably never will be measured. So nobody really knows how they're doing. So listeners can't really see me, but I'm holding my arms up in a big circle. And if everything within that circle is what physicians do that affects how patients make out, then just a little dot in the center would be what gets measured. And really important things don't get measured and probably never will be measured, like an accurate diagnosis. Really important aspect of care. Sometimes takes time, certainly takes listening to the patient, but that isn't measured. So professionalism, where it really comes in is important, I think, is in the vast areas of care where there isn't measurement or reward or penalty for the physicians who are providing the care. Our study is exploratory, really. We can't claim that we've definitively proved that altruistic physicians get better outcomes for patients, so there's a lot of room for more research in this area, which I hope we'll see people do. The last point about implications, I think that said, I think it does pretty clearly make sense, and our study is supportive of this, for policymakers and leaders of healthcare organizations to consider what effects, if any, their actions are likely to have on encouraging or discouraging physicians from acting professionally. Clinicians, when they're trying to decide where to work or whether to stay with the organization they're in, they may want to consider whether an organization in which they work or which they're considering joining encourages putting patients first. And sometimes it's pretty quickly obvious whether it's that type of organization or not, at least in my experience.
Well, thank you. That's actually a nice segue into the way that we like to end our podcast interviews. We like to ask people like you who have had a lot of experience as a mentor, but also were probably mentored well earlier in your career, what the best advice you've been given about your career has been, in particular for developing work like this article published in JAMA Health Forum that is relevant to the medical field and to the policy world.
It's easy to forget who's really helped you along the way, and I'm probably no better than anybody else in remembering. I think there's a number of people who've helped me understand this thing, which I think is really important. The really important thing, I think, for someone who is involved in research on health policy is that it's critical to work on things that you really care about. Otherwise, you might find yourself becoming an expert on a relatively narrow topic for which it's relatively easy to obtain grant funding and therefore to advance your career. But that doesn't actually mean that much to you and might not mean that much to other people either. So think about what's important to you, what you care about, and choose that as an area to study rather than just looking for some relatively narrow thing where there may be some gap in knowledge that probably isn't that big a deal, but that looks good on a grant proposal that you can fill.
Larry, that's good advice. I think a common theme we've heard from some of our other guest authors to focus your research on topics you personally care about and think can make a difference. So our second and last question that we would like to ask you is, what's the biggest change you expect over the next 5 years related to health policy?
I think that the most important thing that's happening from a policy point of view is the rapid corporatization of the U.S. healthcare system. So hospital systems getting much larger through mergers and acquisitions, hospitals purchasing physician practices and employing physicians. Same thing for health insurance companies getting larger through mergers and acquisitions, and also purchasing, just in the last few years, physician practices so that we have one of the largest health insurers being one of the largest employers of physicians in the country now. And then private equity companies purchasing practices, hospitals, nursing homes. There are a lot of factors driving corporatization. I'll just mention that the rapid growth of Medicare Advantage and policies that encourage this growth, it's an important factor in corporatization, for better or for worse. The last point about this is I do expect that as corporatization proceeds, physicians on average may become less altruistic and maybe less committed to their work and their patients than I'd like to think they are or should be. Even for the most well-meaning, really big corporation, it's very difficult, if not impossible, to avoid treating workers, and this includes physicians as widgets, really. And I think that when people are treated as widgets, gradually they begin acting more like widgets, and that's not so compatible with putting the patient first. So I think that corporatization is a big change. It's accelerating. It's already large. And it's one of the reasons that I think this area of research is important.
Well, thanks to our guest author, Dr. Lawrence Casalino of Weill Cornell Medicine. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.